Welcome to the Independence Age Friday briefing. This coming Monday, the government will announce details of its roadmap out of lockdown. But what should that roadmap look like? And what needs to be in place before we can safely start to ease restrictions? Independence Age has recommendations for how to suppress the virus while allowing gradual lifting of restrictions. What we all want to do is avoid surging infection and the need for further lockdowns. Professor Stephen Reischer will talk about those recommendations shortly. Today, I'm delighted to say that we're joined by a very special guest, Dr. Rachel Clark, who I know many of you will know as someone who has been giving us a powerful insight into working in the NHS during the first wave, with her book Breathtaking and her presence on media and social media as well. Dr. Clark is going to talk to us about the reality of living with the virus and what that would actually mean for the NHS. But first, as always, we start with the latest figures with Professor Christina Pargle. Over to you, Christina.
Hi, everybody. Right, let me share my screen. Okay. So this is going to be the latest numbers, and the main headline is that things are continuing to get better, which is good. But it looks like the rate of reduction in infections is slowing slightly, and that's particularly the case in Scotland, as we'll see a bit later. So I'm going to start doing kind of slightly the opposite way around today, but start with deaths and hospitalizations, and then talk in a bit more detail about cases and what case numbers are telling us at the moment, and then just finish on vaccinations. So for deaths, this is from the Office of National Statistics and their equivalent in Scotland and Northern Ireland, which is a number of new UK deaths from COVID-19 registered per week. So COVID has to be on the death certificate. To the 5th of February, it's always lagged a little bit. And you can see that we have now definitely passed the peak, as I said we would last week, and we have, but they're still really high, almost 8,000 deaths in the week to the 5th of February with COVID on the death certificate. But if we look at deaths within 28 days of a positive test reported, which is much more recent data, it goes up to yesterday, we can see that this is still coming down. So you would expect to carry on seeing the ONS deaths fall week on week now, and hopefully we'll never go back to those heights again. Looking at hospitalizations now, this is the number of people in hospital per million people. In each of the 4 nations, it's been coming down steadily since kind of early January, which is really good. And if we just compare where we are now to where we were at the peak of hospital occupancy in April, what you can see is that the good news is that for England and for Scotland, we are now below where we were in April. So we are now below the April peak. Wales and Northern Ireland still have further to go, but both countries are seeing quite steep falls in occupancy. So hopefully by next week, we might get there. So that, I think it is good news now for hospitals that the pressure is easing slightly, even though they're still at high levels. Looking at new hospital admissions with COVID in England, you can see this very steady, quite steep fall since lockdown. That seems to be continuing. I'm not sure we should read too much into this kind of flattening in the last couple of days. And we see that in all regions of England, hospital admissions are coming down. This is new hospital admissions per day, per million people. London, which got to incredibly high levels, has come down the steepest and is now one of the lower regions. And actually what we can see now is that the 2 regions with the highest level of admission still are in the north, so the northeast and Yorkshire and the northwest. And this is actually going to be reflected in case rates, as we'll see in a little bit. But as I said last week, critical care takes much longer to fall. People once they're in intensive care can stay there for quite a long time. And that's a very high intensity resource. And for people working in critical care in the NHS, things are getting better very slowly. You can see things are reducing week on week, the number of beds occupied, but quite slowly, and they're still at every region higher than they were this time last year. So now let's look at cases. Overall, in the UK, the number of confirmed cases is dropping. And we're now back at levels that we were last at the end of the last lockdown in November, which is good. The only thing that I would say is that it's a slight slowing down. You can just see the average, moving average here, slightly flattening off. So compared to last week, there was a 20% drop in cases this week, but a week ago that was a 30% drop. So we can see that the kind of the rate of decline is going down slightly. So we just kind of want to understand a little bit why that is. And it is slowing down in all nations, but it's most pronounced in Scotland and then Wales. So this is looking at the number of cases by date of test. So this goes up to the 14th of February. What you can see here is that everywhere has come down. So we're somewhere between 100 and 200 cases per 100,000 people per week. England and Northern Ireland are still falling reasonably steeply, but you can just see here that Wales and Scotland are starting to kind of have a shallower rate of decline. And one thing I just want to mention is, although we've come a really, really long way from where we were, we've still got quite a long way to go. So just going back up here, in the middle of September is when SAGE recommended its circuit breaker on the 21st of September, where we were at something like 60, 70 cases per 100,000 per week. So, you know, although we're now thinking about how do we come out, just bear in mind that we are still at quite high levels. And just to check that the case rates is giving us, you know, an accurate picture, this is looking at the positivity rate, which is kind of a different way of looking at it, which is a number of people tested who are positive. The WHO recommends that every country should be aiming for something less than 5%, which is this line here, and we're getting there. All the nations are coming down. Again, you can see here that Scotland is now starting to slow down slightly compared to the other nations. And this is consistent with the ONS infection survey that was released today. So that's kind of showing you a similar picture. And I just wanted to kind of show you a little bit more detail in each of the countries, in each of the nations, to kind of show you what's going on. So Northern Ireland, every local authority in Northern Ireland is showing strong drops in positivity week on week. So that's good. It shows that it's quite a consistent drop in Northern Ireland. And Northern Ireland have actually just announced an extension to their lockdown conditions. I think, you know, that carry on driving down the rates there. In Wales, we're also seeing reasonably steady decreases, but there are some local authorities where the positivity rate has jumped up. So the Vale of Glamorgan here in Wales, and some places where it's not really changing that much, like Powys here. So maybe places to watch over the next few weeks. And in Scotland, it is much more mixed, which is kind of what we expect, because we saw that the rate of decrease is slowing slightly. And you can see here that although there are plenty of local authorities that are dropping week on week, there are also some that are the same and some that are going up week on week. And in fact, here in East Ayrshire and West Dunbartonshire and West Lothian, you can see that rates have all increased quite a lot actually over the last week. And I had a look at the testing data. It's not an artifact of testing. This is genuinely does seem to be that there are more cases. And that's something that really that we have to kind of understand a bit more and see what happens over the next week or two. In England, we are still seeing very steady drops in every region, which is really good news. We're still a very, very long way from where we were at the end of August, when we were between 1% and 2% positivity rate. And the other thing to notice here is that in the Northeast and Yorkshire, the rate of decline is slower than in other regions of England. And that is something that we also saw in ONS that came out today. And then we've also see it here in the REACT study. So this is the Imperial REACT study, which reports every month. And they test about 80,000 people for the interim report, which this is 80,000 people randomly selected. So it doesn't rely on people having symptoms to come forward and get tested. And they've shown, you know, that every region has dropped a lot since January, which is the grey bars, which was their last survey. London in particular has plummeted since then, which is really good news since we were, incredibly high. But the northeast, the northwest, and the Yorkshire and Humber, although it's gone down less. And so these are now, the highest regions in England, which they haven't been for quite a few months. And the other thing that I think is quite important in the REACT study is every time they look at a range of different characteristics, and one of the things they look at is deprivation. And what this shows here is compared to the most deprived population, how likely are you to get COVID? And if you're on this side of the line, it means you're less likely to get COVID. And so basically, the less deprived you are, the less likely you are to get COVID. And what's changed since January, which is this side, to this month in February, is that this difference has become more pronounced. So effectively, the inequality of exposure to COVID has increased with lockdown. And that's kind of completely consistent with this article that came out in The Guardian this week from a leaked report from the Joint Biosecurity Council, where they said that England poorest areas are hit by what they called a COVID perfect storm, which is that it's very hard to reduce cases in these areas because people are exposed to COVID, they can't work at home, they're often in poor housing, and also they can't isolate, they can't afford to isolate. And this is causing an issue. And it could be that one of the problems that we're seeing is that trying to get rates below 100 per 100,000 in the context of a new, more transmissible strain, which we have now across the UK, you just can't do it without providing extra support to people who cannot effectively lock down. Effectively, if you're in these communities, you're not really having a lockdown because you're out of work. The other thing that the REACT study showed was looking at cases by age group. So again, grey is January and orange is February. All the age groups have gone down. This is really good news. But for the first time in REACT, cases in primary school age children are higher than cases in secondary school children. That's not happened, certainly not since September. And this could be a reflection of the fact that about 25% of children in that age group are actually going to primary school compared to only 5% of secondary school children. Now, cases are coming down, so that's not necessarily a terrible thing, but we are still seeing from Public Health England that you are still getting outbreaks now in primary schools and nursery school settings. And all it means is that when and if we do go back to school in March, we have to keep a really strong eye on exactly what's going on, and we have to support a safer return. So Independence Age released a report a couple of weeks ago on safer return to school, and we think those measures should really be implemented now to ensure that when we do go back, we don't really start increasing rates in kids and creating more outbreaks. So just finishing on vaccination data, this is really good news. It goes up to the week 17th of February. So about a quarter of the population have now been vaccinated, highest coverage in Wales, but it's very good everywhere. So this is continuing to be really, really good news. And we've kind of seemed to have stabilized at about 3 million people a week receiving a dose of vaccine. Looking at just the coverage by kind of vulnerable groups, again, this is really high. So in the kind of top 4 groups of 70 and above, over 90% of people have had their first dose, almost 100% of people 75 to 79 years old. And then now starting with the next priority group, so 15% of people under 70 have already been vaccinated. So this is, I think, is genuinely really good news. However, there's also inequality here. So the Independent ran a story this week showing that poorer areas, again, are falling behind on vaccination against coronavirus. So they're both much more exposed to it, more likely to get sick if they get COVID, and are now being less protected by vaccination. So compared to national figure of 93% of over 80s having received 1 jab, in East London, for instance, it's only 73% of over 80s. So I think, if we genuinely want to protect the population, we have to protect everybody. And that means making sure that we reach out to people in more deprived communities to support people to be protected. Just wanted to show you a couple of slides on the potential progress of vaccination. So what can we expect over the next couple of months? So this, I actually kind of did some analysis like this, and then John Burn-Murdoch at the Financial Times did it in a prettier way. So I'm showing his graphs. And this is assuming that now we're at 3 million doses a week. We'll stay at 3 million doses a week. And what it's saying is that by about the end of March, pretty much everybody in the top 9 groups will have had their first dose. And so what that means is that you're starting to then hit the stage where people are going to need their second doses in April. And because we've been vaccinating 2 to 3 million people a week, once you get to May, all of your vaccine doses need to go on second doses. So we should be expecting that if we do not increase the capacity for about a month, you'll end up basically just giving second doses to people, and the kind of first doses are going to have to wait. And they'll wait until about June or July before they can start vaccinating people again with a first dose. And if that kind of continues, then by September, you should have been able to provide a second dose to all adults in the UK. If, however, we can increase capacity up to about 5 million doses per week by summer, and that seems perfectly realistic, you can then still carry on vaccinating people in their first dose while still making sure that everybody who's due their second dose gets it on time. And if we do it that way, we should actually be on track to vaccinate all adults, fully vaccinate all adults by mid-July. And that to me is a really, really good target to aim for and a really positive one. So I think this could be a really good news story. So just to summarize, cases, hospitalizations and deaths are falling everywhere, but there are some kind of early signs of a slowdown. Vaccination is going really well. And we now kind of have to think about, what is a strategy for coming out of lockdown? How do we ensure a no lockdown future? And so I'm now going to stop sharing this and then hand over to Steve to present the strategy. So I'm just going to, give me a sec, Steve. Great.
Okay, thanks, Christina. You did that far more efficiently than I'd have been able to, which is why you're still in charge of the technology. Okay, so having seen the figures, I'm now going to speak to the strategy that we propose in order to move forward from here and to move into the future. And I want to start off with a misconception, I think, that is quite current, which is that many people, many of our critics, seem to suggest that we, for some reason, are keen on lockdown. Not only are we not particularly keen on lockdown, we, as much as anybody else, want to be able to go out and meet our family and friends and to hug our close ones. But actually, the whole point about the strategy we suggest, what we call a sustainable suppression strategy, is that it's all about driving the levels of infection down sufficiently and keeping them down at a low enough level so that instead of having to use the blunt instrument of lockdown, which you have to do when levels are too high, you can use targeted local measures, sustainable measures. And therefore our strategy is an anti-lockdown strategy. And as we've always argued, lockdowns are a sign of failure. They are the failure of these systematic and sustainable measures. So let's go on and begin to address in a little bit more detail what we're talking about. The Prime Minister has voiced an aspiration to come out of lockdown carefully and to stay out of lockdown. And he stresses the need to stay out of lockdown. And we completely agree. We share that aspiration. But our question is, how do you turn that aspiration into a reality? And the problem is that if you only talk about the measures that you're going to lift without talking about the ways in which you're going to keep infections low, then always that will happen, as happened in July and then happened after the circuit breaker in the autumn, is that infections will go up again and you will again yo-yo in and out of lockdown. And that's the worst of all worlds. So we need a systematic strategy to keep infections low and to drive them lower. That's always been missing. It still is. So the thing we should be looking out for on Monday when we hear the roadmap from the Prime Minister is not only what he's going to lift, but what is he going to do to make sure that infections stay down and keep on going down. Now, going on, one thing that is different, and the government will probably stress, are vaccinations. And vaccines are certainly part of the strategy. We are as enthusiastic as anybody else about the vaccines. We are all very keen to get vaccines as soon as we can. Some of us have got them. I get mine at 11:48 precisely tomorrow morning, so I'm looking forward to that. But this is the key point. Vaccines are part of a strategy, but time and again, the government has put all its eggs in one basket and suggested something is the magic bullet that will save everything. And vaccines are not the strategy, they're part of the strategy. And still worse, we are hearing voices at the moment who say that when the vulnerable groups have been vaccinated, then let's open everything up and let the infection rip. Now, that was always an appalling idea, partly because younger people still get infected and they still have to go to hospital. So if you did that, you'd overwhelm the NHS. Secondly, because many thousands, probably tens of thousands of people would still die. And we're learning more and more about long COVID. And so how can we condemn all of the population, bar vulnerable groups, to long COVID? But now more than ever, there's a new factor, which is that if you let the infection rip, if you let it circulate, in effect, you give it a free pass to find new ways around the vaccines. The more infections, the more mutations, the higher the probability of new variants that get past the vaccines. So those who say open up immediately, those who say live with the vaccine, are actually suggesting something that is incredibly damaging and ignores the realities. And in a moment, we're going to hear a lot more about those realities, what it means to so-called live with the virus. On the whole, it means to die or to suffer with the virus. But so what should the measures be? So let me go on and outline what we call the 5 pillars. One is indeed vaccination for the entire population, the adult population, but children as well, because children can transmit the virus. So vaccination for everybody. The second thing, and I do apologize for banging on about this, we talk about it, so David talks about it at the end of nearly every session that we have, but for very good reason. Testing is absolutely critical, widespread testing as part of a local public health system, something that is rooted in the community so that you can trace people, that the tracers are trusted. That's something which is so simple and so obvious. And we've spent probably nearly £30 billion already and not achieved that. So that's still completely critical. But more than that, it's the third point, you can test all you like and you can trace all you like. But the whole point of testing is to break the chain of transmission by getting people to isolate. And if people practically can't isolate, you are wasting your £30 billion. So it makes no public health sense. It makes no economic sense not to support people to self-isolate. And again, it's one of the things we talk about all the time. And it's worth asking every day to the Prime Minister, why aren't you supporting people to self-isolate? The next idea is something we've also talked about, but we want to, in a sense, lay more stress on, which is we need to make our public spaces safer so people don't get infected in the first place. We need a gold standard to ensure mitigations are in place in our schools, in our workplaces, in hospitality, so that when they open, people are properly distanced, there's decent ventilation, there's decent hygiene. Now, we all accept every time we go to a restaurant that we expect the kitchen to have a certificate up giving it a hygiene rating, and that if it doesn't have that hygiene rating, it shouldn't be open. We should use the same principle in all our public spaces to make them safe so we don't get transmission. And finally, we do, for the moment, have to make a trade-off between opening up nationally and limiting travel internationally. It's a bargain, but if you go to Australia or New Zealand, where at present they go to pop concerts of 30,000 people and they go to restaurants and they go out and they socialize, I think they would tell you that it is a bargain very much worth taking. So with these 5 pillars, these 5 measures, all of which we can live with, we can begin to reopen. So what should the process of reopening be? That's what I'm going to go on to next. So our first point, and it's a point many people make, is data, not dates. If you give people a date for reopening, all you're likely to do is not give them hope, but dash their hopes when the realities say you can't open at that point. So we need clear data-based criteria, and we need to reopen carefully and gradually on the basis of the things that we think are most important, and we nearly all agree. The most important thing is education. So we should start reopening schools. And we brought out a report a couple of weeks ago about how that should be done, stage by stage, starting with smaller classes, starting with more mitigations. We should start that when incidence is below 100 confirmed cases per 100,000 population per week in all regions. That's the point at which we can begin to say that we can reopen without the level of infection running back out of control and getting back into exponential growth and having to close down again. And we should monitor the effects of that early cautious reopening of schools before we do anything else. If you open everything up at the same time, all you're going to do is to get back into crisis. If you try to have everything at the same time, you'll end up with nothing. And so we need to continue to apply the measures we've spoken about, those sustainable 5 pillars, and monitor the effects and monitor the fall in infection. And when the fall in infection gets to a point where incidence in a locality falls between 10 confirmed cases per 100,000, we call these green zones. And full opening is possible with the 5 safeguards in place. And that's the point at which, if there are infections, you can deal with them through a proper test and trace system, through supported isolation, and so on. And this is the way, we would argue, to reopen and to stay open, to get to a point where we can manage COVID, not with the blunt instrument of lockdown, but with the targeted instruments that we've described in our strategy. And so with that, I'll finish talking in general terms, and we can go on and hear in reality what the opposite is like, what it means when people say, let's live with COVID.
Thank you very much, Christina, for the figures, and Stephen for that idea of a workable roadmap out of lockdown and a way of preventing another lockdown in the future. And now we're going to hear from our special guest, Dr. Rachel Clark, who's going to talk about her own experience of working in the NHS during this pandemic. Rachel, over to you.
Thanks, Alice. I really want to try and succinctly convey in real lived experience what the alternative is to the strategy that Steve has just described. And on the front line of the NHS, we've been living that for the last year. It's really impossible to exaggerate just quite how grueling conditions have been inside hospitals and inside every part of the NHS caring for patients with COVID. The numbers from the first wave onwards have been on a scale none of us have ever experienced in our lives. And that has caused just first and foremost sheer physical exhaustion for frontline staff, but not only that, a real emotional toll on staff as well, and that's for a number of reasons. So first of all, just the sheer quantity of death and dying. We, as everyone knows, we've had over 125,000 deaths due to COVID in the last year since this pandemic began. And when you are at the front line of seeing patient after patient after patient coming into hospital with the same symptoms, dying in the same way in numbers unimaginable to any of us, that hits you hard. I'm a palliative care doctor, so I'm used to seeing death and dying close up. I know what it's like, but it's still been unbelievably traumatic. And then for a great many staff who are not used to seeing dying intimately at work, it's been shocking. The alternative to vigorous and aggressive suppression of this virus is a continued experience for all patients of healthcare being provided in a way that's fundamentally transformed by the infection control measures you have to have in place to stop transmission of the virus in healthcare settings. So PPE, we're all familiar with the idea of PPE, we all wear masks, but if you think about that from the perspective of a patient coming into hospital with COVID or cancer or heart disease or any other condition, and perhaps going on to die from that condition, what that actually means is from the very first moment you arrive in hospital, you are destined never to see a single human face again in your lifetime, because absolutely everyone around you, whether they're a professional or a visitor, a member of your family, is going to be masked. So you will not see any lips or cheeks or smiles. You will only see masks and eyes covered by visors. And for patients, that's obviously devastating. For staff, it's devastating too, because all of the ways in which we want to try and convey compassion and humanity to our patients, and we are all doing everything we can to achieve that, but all of those ways are just subverted and twisted by PPE and also by the lack of family members at patients' bedsides. And sometimes it is unbearable for staff to see the kinds of barriers that are in place. The third thing I think we need to be honest about when we're talking about alternatives to a vigorous suppression strategy is rationing. And the government, and I think NHS England, have united really in trying to downplay the matter of rationing. But the truth is, for months and months and months during the last year, it is absolutely the case that NHS care has been rationed. You only need to take the example of intensive care medicine to see that. So normally an intensive care nursing ratio should be 1 nurse to 1 patient, or maybe 2 patients. Actually, in this second wave, and again in the first wave, we have had those ratios relaxed so that 1 nurse may care for 4 or even 5 critically ill patients. And what that dilution means is it's not intensive care anymore. It's just not the intensivity that those patients need. All kinds of other ways in which care has been and continues to be rationed. There are patients who should be having their cancer operations right now, and they're having those operations delayed over and over again. Last month, there were patients in London who couldn't get ambulances to bring them into hospital. There were patients with COVID who resorted to calling Ubers to bring them into hospital because they were told the delay for an ambulance might be an hour or more. Another form of rationing, which potentially, and I think in fact, costs patient lives. So that's the alternative. The issue has never been about protecting the NHS. No one wants to protect an institution. This is about ensuring that we, NHS staff, are able to care for all our patients, COVID and non-COVID alike. And we can't do that if the levels of the virus are too high. If we think forwards about what's going to happen from this point onwards in 2021, we have a really difficult set of circumstances in which we have a workforce that is profoundly depleted. We have rates of PTSD, severe anxiety, severe depression among staff that papers show are around 50% of staff that have been surveyed. There was one paper that came out last month which showed that 1 in 7 of ICU staff reported thoughts of self-harm or suicide. I know that where I work, I've talked to colleagues who say openly that they're feeling suicidal. They're actually having thoughts of taking their own life because of what they've endured. We also have a context in which now we've got nearly 5 million patients on waiting lists for their elective surgeries, and some forecasts suggesting that that figure is going to double by April. So by April, we may have 10 million people on a waiting list needing their operations. How exactly is the same finite, depleted, traumatized, exhausted NHS workforce meant to address that backlog of up to 10 million patients on waiting lists? How are we meant to start doing all of the cancer care and treatment and chemotherapy we have so wanted to do throughout this year but haven't been able to because of COVID? The key here is not hospital beds. It's never been beds. NHS capacity isn't about inanimate objects. It's about people, the workforce. There are only so many of us, and we're ground down. The one thing that can help with this impossible task is, of course, to keep transmission of the virus as low as is humanly possible. For example, through those 5 pillars that Stephen has just outlined to everybody. The higher the transmission of the virus, the greater the number of patients with COVID that we are trying to treat in 2021, the less energy and capacity we have to treat everybody else in the NHS. This is about how do we care for the greatest number of patients to the best possible standard. And I think that this is something that is often missing from the debate. The public debate is always around how quickly we can relax lockdown and whether or not, what impact that will have on cases. It's not quite as simple as that, because you need to follow through the impact of rising cases on NHS staff's capacity to care for all patients. The lower the transmission of COVID, the better we can care for everybody. So if there is one single overwhelming moral imperative for why we need to lock down cautiously and crucially have all of these longer term measures in place in 2021, it is because that is the way to enable NHS staff to care for as many patients as possible from here on in. And I think that as an argument is unbelievably powerful. If we want to care for society's most vulnerable members and people with illness, whether it's physical or mental illness, are particularly vulnerable, then that's the reason to keep transmission as low as possible. Thanks very much.
Rachel, thank you so much. And thank you for carving out the time today to speak to us and provide your powerful testimonial about the scale of the challenge and also that human experience from inside the NHS, both from a perspective of a member of staff, but talking about patients as well. And we're now going to open up to questions. And the first question comes from Jonathan Ashworth, who is Shadow Health Secretary and Labour MP for Leicester South. Jonathan, are you there with your question?
I am, and thank you as always. Incredibly powerful presentation there, Rachel, as usual. And I always in huge admiration for the work that you do and the way in which you campaign as well. And I read your books and all your articles, and brilliant presentation as usual from Christina and Stephen. My big worry is that we obviously went into this crisis knowing that we had a social gradient in health outcomes. And I believe that's reflected with COVID as well. And that we are seeing a big COVID divide opening up. The rates are falling more slowly in poorer areas, including my own here in Leicester, where I am at the moment. And we're beginning to see a vaccination COVID divide as well, as Christina highlighted. How do we safely ease from a lockdown and ensure it is the last national lockdown, as you've rightly said, while not leaving communities like mine here in Leicester behind? And Leicester, you will know, was the first test case for the Prime Minister's whack-a-mole strategy last year. And even under our own version of a lockdown, cases, I think at the lowest point in midsummer, we were around 22 cases per 100,000. So how do we ensure that poorer areas with poor housing, with people who have to go to work, overcrowded housing, cities like Leicester and so on, are not left behind in this?
Thank you very much, Jonathan, for that question. something which we've been very, very concerned about on Independence Age over the weeks and months is the deepening inequality that seems to be, was there right from the beginning, but we're still seeing it very starkly now, as we've seen in Christina's presentation this morning. I wonder if Zubaida, you'd like to start with that, Dr. Zubaida Haque.
Thank you so much for that question, Jonathan. I think it's really important in the context that we're in right now. You almost answered your question, because one of the things that's really been missing in this pandemic is the slogan, if you like, and the Prime Minister has used lots of slogan, that no one should be left behind. And that should have included areas all along. We know that that was a problem when we came out of the first lockdown, that the Prime Minister didn't look towards the north, didn't look at places like Leicester, and eased us all out of lockdown, leaving those places not only behind, but in perpetual lockdown. Now, what we need to do this time, with that motto that no one will be left behind, is protect those poorer areas, is resource those poorer areas so that they can come out of lockdown. We know that the poorer areas have higher rates of poverty, high rates of overcrowding, and high proportions of Black and ethnic minority groups who are in low-paid jobs, insecure jobs, so that they're having to go to work while the rest of us are staying at home, and who are also living in overcrowded and multi-generational housing. The leaked report by the Joint Biosecurity this week showed exactly that poorer areas and Black and ethnic minority areas were overexposed to the virus and underprotected. So what we need to do is, once again, as Stephen said, and I know I always say this, is go back to that test, trace and supported isolation. We need to financially support people so that they can self-isolate. And this is very important, we need to also provide them with accommodation, with hotels, so that they can self-isolate. And we've seen that in examples like Newham.
Thank you very much, Zubaida. I know there's a couple more people that would like to answer this question. Professor Gabriel Scally.
Jonathan, good question. And you are well aware of things like the stalling and the life expectancy, and how in many of our poorest communities, life expectancy has actually fallen over the last 10 years for some groups. And all that COVID is likely to do is make that worse unless we really react very strongly in the knowledge that we need to do something to protect those communities and to help those communities. And one of the difficulties in doing that, of course, is that the government hasn't really reached out to those communities and moved resources and supported those communities. There are directors of public health in every local authority area in the country, and in many places they are struggling with resources and very small teams that have been left to them after after several years of cuts, and without the power and the influence to be able to make a difference. And I do fear that every time we have one of these lockdowns, the government just sits on its hands and waits and waits and waits, and doesn't do the things during a lockdown that they need to do, like giving the resources to local directors of public health to build up their teams, like changing the testing strategy to bring it into line with international guidance. It is a complete disgrace that the UK is not testing high-risk people, close contacts of those who have been diagnosed positive, have a positive test, are not being tested. They're being asked to self-isolate and only come for testing if they develop symptoms. So we're missing a lot of asymptomatic people and not detecting a lot of people early on. So a proper testing strategy, local resourcing for local authorities and their directors of public health has to be a key way of those communities, and working with the community leaders, that we know that many of those communities are very strong community leaders, and we need to work with them and help support them. But it will require a substantial effort by the government. It won't happen by itself.
Thank you very much, Gabriel. I'd like to bring in Dr. Tallulah Onie, then Professor Costello, Professor Pargle as well. So Tallulah, over to you.
Thank you for the really important question. I think fundamentally what we're speaking about here is an issue of building and sustaining trust, right? So both direct and indirectly. My colleagues have spoken about the direct aspect. So you build trust by making it easier for people to isolate, for supporting and reducing their exposure. But the indirect ways, and I'm getting these questions and saying, why does the government want us to take a vaccine now? Why aren't they pushing for healthier foods and making it easier for us to exercise when we know that there's my answer is that's not good enough, because actually we don't do enough at protecting people by reducing their vulnerability. Right? We're dealing with this issue now. So I just want to highlight the issue, bringing trust in, to say addressing the trust is a matter of addressing the current issues around COVID exposure, around being able to isolate, around even uptake of vaccine. But it's really critical that we're doing this alongside and simultaneously with addressing the wider exposures that increase the vulnerability to COVID and other conditions in the first place. And people intuitively know what these are. So we have to be meaningful and purposeful about addressing the housing inequality, the public space inequality, the healthy access to healthy foods inequalities as part of building a resilience both to COVID and to other conditions.
Thank you, Talila. Professor Anthony Costello.
I think what successful countries understand, many of them poorer than us, and unsuccessful countries, not just the UK, but many in Western Europe and the US, is the importance of having a presence in communities, a community health workers, probably with a coverage of around 1 per 1,500 to 1 per 2,000. So teams of, maybe 5 or 6 for 10,000 people. People who have the trust, so they could be retired health professionals or community leaders with links to vulnerable communities, and who are going to have an impact. And you measure the impact with key performance indicators like finding cases, isolation compliance, vaccination amongst very vulnerable groups where there may be hesitancy, and of course, providing the reassurance and sharing information that people need in communities. Now that was, we used to have health visitors, we used to have district midwives who visited every mother. This was in the time when I first qualified. That's all gone, largely gone. And that's why we need it, because GPs can't do all of this. They're busy enough in their practices. And I think that's a lesson we have to learn. I thought we would have learned it or understood this last February, or again in July when the rates were very much lower, but we don't seem to have learned it even now.
Thank you very much, Anthony. And thank you very much for bringing that question today, Jonathan. Moving on now to some questions from members of the public. And the first one comes from Adrian Penfold from Kent. Adrian.
Hello. If this is a virus that constantly adapts, then presumably vaccines produced are going to have to continually be updated. So my question is, how long are countries that adopt a zero COVID strategy going to have to isolate and maintain a closed border policy?
Thank you very much for that question. I'm thinking that Professor Deenan Pillay might be a good person to start with that. And then if anybody else wants to come in, let me know. Deenan?
Thanks for the question. Well, there's a number of different approaches to answering that. You started off by asking about as the virus continues to adapt, and I'll touch on that. And there's also the issue of how we come out of and clarifying, as Steve has done, how we come out of lockdown. Maybe my colleagues can also chip in for that. But you're right, is that the virus will continue to adapt. And that adaptation is itself a function of how much virus is circulating. So clearly in those countries with very, very little virus, New Zealand and Australia and so on, there's not many virus variants there, because there's not much virus there and there's not much transmission there, although of course there continues to be the threat of importation. I do think that vaccines, practically, that vaccines will need to be adapted. I think that's becoming the consensus view. And the paradigm there is what we already have with influenza vaccines. Every year a different vaccine is developed that is is targeted against those viruses, those strains that are circulating. So I think there's nothing new here, and the technology allows that. I think the critical thing is how we ensure at this stage, as vaccines are being rolled out to cover the population, how we ensure that we maximize the effectiveness of those vaccines. And that is the critical thing. Clearly, if we roll out vaccines now to the whole population, it may be September, October until we've covered the whole population. If during that time we've got large amounts of virus then circulating, then clearly that's going to compromise the ability of those vaccines to work. Once the population is vaccinated, then I'm sure there will be a different dynamic of infections over time, and whether there needs to be the regularity of boosting and so forth then becomes an issue. So I think let's focus on the here and now, and what we do now to maximize the effectiveness of the vaccine rollout is the critical thing. Thanks.
Thank you very much, Dean. And I wonder if anybody would like to tackle that second part of Adrian's question, which was, it's probably an extremely difficult question to answer because it involves a bit of crystal ball gazing. But how long will countries have to stay isolated if they do follow a maximal suppression strategy, a zero COVID strategy? Christina.
So my answer is that I don't know. But I think what Dean said is the crucial thing. Like right now, we are rolling out the vaccine, and to make sure that we don't waste that rollout, to lock in the gains that we've already got by vaccinating a quarter of our population, we have to stop new variants arising here this summer. And I guess my view is that once we have got to the stage of vaccinating, or at least offering a full vaccination to every adult, and hopefully early next year children, when that becomes approved, then I think you're in a situation where you look and you reassess and you go, okay, where are we? Where are we in the world? What do we know about new variants? Well, we will know so much more then that you come back to it and have a whole new discussion about your strategy in the longer term. I don't think we have to solve the next 5 years right now, because all of the measures that we've suggested for this summer are perfectly applicable to the future, and you just adapt to where you are then. I don't think we have to say, I know exactly where I'm going to be in 3 years' time. So I guess that's my view.
Thank you, Christina. Professor Susan Michie.
Yeah, thank you, Adrian. I mean, your question of how long is, I think, it comes from the last year when we've been given different dates or different perspectives of when different things are likely to happen. And the phrase that I'm very pleased, I think, is catching on is to be guided by data and not dates. So in some ways, I wouldn't ask that question. I would ask the question, what needs to be done to maximize the chance that we will be able to lift the current restrictions that we inevitably have to have at the moment? And those would include border controls, but that would include many other types of restrictions. So the more things that we can put in place and do so effectively, the quicker we'll be able to lift various restrictions. And we should be looking for where have we got headroom now. The test, trace and isolate system has already been discussed. Big headroom there by doing a root and branch reform of it, bringing it into local public health, primary care, NHS that has delivered the vaccination programme so well, and stopping the failed contracts. Another bit of headroom is that we have data that 1 in 5 of people who can work at home are having to go out to workplaces on transport, mixing with other people. Again, that's another headroom. So there are several ways in which now we could be doing things differently. And Zubaida and others have talked about that in terms of deprived communities, which could maximize the chance of getting to that sooner rather than later.
Susan, thank you very much. And Professor Stephen Reischer.
Yeah, so just to echo that, not dates, not data, and not when, how. So how can we bring that period sooner? And Susan has talked about the domestic things we can do. The other thing, of course, is that it underlines is the issue that was the topic of our briefing a week or two ago, which is vaccine globalism, that it is absolutely essential to roll out the vaccine and to ensure the vaccine is rolled out across the globe, because the more that we can support other countries to suppress their own virus, then the more it helps all of us. So I think for me, not only does that pivot from when to how is it more functional, but also it gives us more agency. If you just give a date, it renders people passive. You just wait for that date to come along. And then that hope turns to despair when you discover you can't do things. If you give people agency and you say, what can we do to bring this sooner, then you bring the population into the effort. You make us feel that there is something we can do to make a difference. And I think there are a whole series of things we can do, both domestically and critically, internationally as well.
Thank you very much, Stephen. Thank you for the question, Adrian. Moving on to Andy Corney from Norwich. Andy.
Hi, everyone. Can you hear me?
Yes, we can. Go ahead.
Brilliant. Thanks. I'd just like to start by saying thank you to all of you for what you provide, particularly on Twitter. And I'm an avid Twitter freak, as they say. It's been stunning. I just can't believe the government don't listen to you all the time, frankly. My question is, why is it that scientists disagree whether and to what extent children transmit COVID?
Thank you very much. Great question. There's a lot here about absence of evidence being used as evidence of absence. Who'd like to start with this? Zubaida, you've talked a lot about transmission in children and schools. Would you like to take this?
I think that's a very important question, Andy, but I'm not entirely sure that that is the question when it comes to schools, if you don't mind me saying. I've been perplexed by why aren't the media, why aren't the government focused much more on the question of what do you need to do to open schools and how can you ensure that they stay open? There's been so little focus on the mitigating measures in schools and how important that is. And the way I see it is, I mean, we've already seen, Christina mentioned the data that's come out that's shown that at the moment, even during lockdown, primary school children are the most infectious group. Now, of course, at the moment, we know that there are approximately 1 out of 5 primary school children in school for all sorts of reasons. They shouldn't probably all be there, but they are. But what that suggests to us, or what that begs the question of, is if there were more mitigating measures, if there were more COVID secure measures in school, would that figure be as high for primary school children? Would they be as infectious? And more to the point, if they're this infectious now, if they're the most infectious group now, what will happen on March the 8th when the government decide to open up all schools for all children without COVID secure measures? So if you don't mind me saying, I think that's a really important question right now, which is why are there not more COVID secure measures in schools, given that we know that they will make a dramatic difference?
Thank you very much, Zubaida. There was a comment from John Edmonds of Sage, which went somewhat under the radar, I think, back in January, when he said that the primary route of infection into households during the autumn was school children. So we heard that, but it didn't seem to create much of a ripple. Dr. Kit Yates, you'd like to comment here?
I think I completely agree with what Zubaida said, that we should be focusing on how to make schools safer places. The reason why I'm concerned that when we get kids back into school that we may see not just rises in R but pushing R above 1 is partly based on a study by the London School of Hygiene and Tropical Medicine earlier this week, which again went relatively under the radar, which suggested that it was going to be really difficult to keep R below 1 when we get all children back to school, which is why we've been consistently advocating putting in better safety measures in school, and why it's so disappointing to see that almost nothing has been done to make schools safer places to reduce the potential for transmission. We're talking about trying to come out of lockdown and schools being the test case. I'm a bit worried, to be honest, that we're going to fail at the very first hurdle, and then where does that leave us? So I think more could be done to try and make schools safer places, and we released our Safer Schools document a couple of weeks ago, which you can find on the website to see how we suggest you might do that.
Thanks very much, Kit, for that, and thank you for the question, Andy. Moving on now to Catherine Harper from Merseyside. Catherine.
Hello, everybody. Thank you for inviting me to ask a question. And thanks for all the work you've done all year. I've been watching it avidly every week. I think everybody should watch this. I'd like to ask a question about lateral flow tests. The NHS have introduced twice weekly lateral flow tests for patient-facing staff, and also for other care settings, hospices, and also you just talked about schools as well. I'm from Merseyside, and given that the Liverpool pilot reported recently in the BMJ that only 48% accuracy was found in the lateral flow tests, what do the panel think about the use of them? Could they not cause people who have a negative result to drop their guard a bit? I'm just really confused about their role within the testing process.
Thank you very much for that question. And Kit, you'd like to come back on that, and I'll come to you, Professor Martin McKee.
Thanks for the question, Kathy. I think it's a really good one. I think lateral flow tests and mass testing does have a role to play. I think it's potentially a really good way of finding people who are positive. But as you suggest, there are reasons to believe that there are false negatives, non-trivial rate of false negatives, so people getting a negative result when they're actually positive. And what we shouldn't be telling people is you can use this to say that you don't have COVID at the moment, that you can go and do something that you otherwise wouldn't do if you do have COVID. So the other thing that I want to make a little bit clearer is this false negative rate that's been reported of around 50% is in comparison to PCR testing. So PCR testing can pick up when people have had the infection but aren't necessarily still infectious. Of course, it can pick up people who are infectious as well. But lateral flow tests have a slightly better sensitivity for picking up people who are genuinely infectious. So it's not quite as bad as the 50% figure that's reported. But that said, just because you get a negative test result from a lateral flow device test, you shouldn't assume that you don't have COVID. So I think they have a role in terms of catching people who are positive and asking them to self-isolate and to do things differently, but we shouldn't be using them to tell people that they're negative and that they can go about their usual business.
Thank you very much, Kit. Professor Martin McKee.
Yeah, thank you very much. It's a really important question. Actually, we published a paper in the British Medical Journal recently. Ian Buchan from Liverpool is one of the co-authors in it, where we tried to look at all of these issues. And just to reiterate what Kit said, these are good ways of finding people who are infectious. They're not good ways of excluding infection. And the key message, I think, that comes out of the Liverpool experience is that we need to find ways of using them by working closely with the communities affected. There are niche areas. So, for example, repeated testing, they did it with the fire crews in Liverpool because there was a problem that everybody was having to isolate whenever one person was a contact of somebody else. So finding the niche, finding exactly the area where they are useful and then applying them. But that does involve engaging with communities, which goes back to a point that was raised earlier. The big advantage of them, of course, is that the results are fast. And we have to remember that with the PCRs, you do have a delay. And in that delay, you will then have the potential to transmit it on to other people. But the answer is they've got an important role, but we need to work out exactly what it is in what circumstances.
And don't change your behaviour if you get a negative result. Professor Susan Mickey, if you'd like to add something here.
Yeah, just to say with tests and with vaccines, it's so important how these are delivered because they're only one tool in the toolbox and other tools are behaviour. And there's a real concern about, even if it's explained, that people may still think, phew, I haven't tested positive, and let their guard down. Similarly with vaccination, so important that people who are giving the vaccinations explain that this doesn't mean 100% protection. It doesn't mean protection within the next 2 weeks. We don't know how long this is for. So the communication around tests is absolutely key. And the other thing is, who's delivering them? If people are administering them to themselves, we know that that's going to be much less accurate, especially if in some cases people won't want to know a positive test result because they won't be able to isolate, because they won't be able to afford it. So the way in which tests and also vaccinations are delivered are incredibly important.
Thank you very much, Susan, and thank you for that question. Moving on now to Tom Magner from Carers World Live. Tom, you join us again. What's your question?
Yep, thank you very much indeed, Alice. It's a different subject from the one you've been covering. We're hearing from a worrying number of viewers who can't wear a mask for medical reasons, but are being subjected to abuse when out and about for essential purposes. It would help me to investigate their concerns in more detail if the panel could explain the scientific, medical and/or social basis of these exemptions and what are the qualifying conditions, for example. Thank you.
Thank you very much. I wonder if anybody on the regular panel has a perspective on that. But I also wonder if, Rachel, you've got a perspective, because obviously masks are part of PPE much more regularly in hospitals. Are there normally exemptions in hospitals for people with various conditions?
So absolutely, but there's nothing too draconian about what those conditions are. So it's entirely possible for somebody to, for instance, because of events that have happened to them in their past, feel completely overwhelmed psychologically and constricted by wearing a mask. And that doesn't come down to anything physical or physiological, but it's an entirely legitimate reason why someone may struggle to wear a mask. And I think even though I'm somebody who's incredibly pro-masks for obvious reasons, I think it's really important not to stigmatize or attack anybody who, for genuine reasons, whether they're physical or psychological, finds it very difficult to wear a mask. And certainly if I see somebody not wearing a mask in a hospital environment, for instance, I will not leap to judgment, because there may well be very genuine reasons why they can't. I think it's really difficult because we know there are also a small but very vociferous minority of people who oppose mask wearing almost on ideological grounds, and that complicates things. Some people wear a mask, a badge that says something along the lines of, I can't wear a mask, or I have reasons for being unable to wear a mask. And I think if that happens, we certainly, healthcare professionals, take that at face value and respect it. But, and I think I'm not aware of a definitive list of conditions that defines issues with mask wearing. There's a lot of nonsense talked about on social media, for instance, about the fact that if you wear a mask, then you're going to experience hypoxia, reduced blood oxygen levels in your blood. That's absolute nonsense. I noticed something on Twitter this morning where somebody who purported to be an American doctor insisted that absolutely anybody who had cancer should not wear a mask. Clearly that's obvious, but equally people are frightened and vulnerable and have been from day one of this pandemic. So it's very easy to try and manipulate people. So my position as someone who is fanatical about wearing a mask myself is we need to be really careful and respectful of people who can't for whatever reason.
Thank you very much for that, Rachel. I wonder, Stephen, if you've got a perspective to add here.
I mean, I think this comes back to a wider issue of how we view each other as a public. And one of the things that's always concerned me throughout this pandemic has been the narrative of blame that's come from government, that they overemphasize the extent to which people aren't complying, that at one point they even suggested that we report on our neighbours. The police quickly told them what a stupid idea that was. But a broader narrative that your neighbour is a problem. Whereas all the evidence throughout the pandemic has shown us, number one, the levels of adherence in areas where people can adhere easily. I mean, areas like self-isolation are different because they're difficult to do, but where people can do it, not only do the figures show high levels of adherence, if anything, they've gone up over time. Mask wearing has gone up over time. Social distancing has gone up over time. And what that tells us, by and large, is people are adhering. And they're adhering on the whole, as much for their community as for themselves. In fact, for many people, especially young people, we blame young people especially, but young people are adhering, even though they themselves are less likely to suffer, they're adhering for others. So I think we need much more of an understanding of the high levels of adherence, the high levels of solidarity, so that we don't gaze upon our neighbours or others as if they're problems, that we think not what they're doing wrong, but how we can help them and how we can support them. And I think if we and the government, because they're responsible for this narrative of blame, and the media, because they love nothing so much as a good story of people violating and going to a house party, told the reality of that support, then we would be less likely to get into those situations where people who don't wear a mask are seen as problems. And we would start from the premise that actually people, when they can, do wear masks. And if they don't, there's probably a pretty good reason. And one of those reasons might be actually they have practical difficulties. One of those reasons might be even issues of can they afford to get masks. So we should always start from our premise, the premise that our neighbours aren't a problem, they're part of the solution. And we shouldn't gaze on them with distrust. We should ask how can they support us, but also how can we support them? And I think that's the fundamental way to address this problem.
Thank you so much for that, Stephen. And Tom, you may have seen these already, but Christina's just reminded me that there are a couple of briefing notes available on the website, one about racialized stigma and recommendations for promoting social cohesion, and another one on use of punishments in the COVID response. We should say we don't support punishments in the COVID response.
Yes, excellent. Thank you for those references as well. Those detailed answers, really helpful. Thank you.
Thank you, Tom. I'm going to squeeze in one last question. I always try to do this. Peter Taylor from Stafford. Peter.
Yeah, thank you for giving me the opportunity to ask a question. My wife's clinically extremely vulnerable, and she's had her first Pfizer vaccine just over a week or so ago. The latest government advice is that people who are shielders should remain shielding at least until the end of March, even if they've had a second injection. Notwithstanding any government guidance and regulation, what's your view on if and when, in terms of case rates that is, shielded people who've been vaccinated with both doses will be able to return to some sort of normality and once again meet family and friends? And a supplementary bit on the end of that is, will they need to take any extra precautions in view of the recent emergence of certain variants of concern? Thank you.
Thank you very much for that question. Is anybody able to give any advice here, or not advice, but just a bit of context and perspective? Martin McKee.
Well, yeah, it is a difficult one. And so I suppose working from first principles, the thing that we do know is, of course, the vaccines are all very effective, but they take a while before the immunity becomes effective. You need to wait at least 2 weeks to get the immunity, and you will get a greater level of immunity after the second dose of the vaccine. But even so, anything that is, say, 95% protective, that will reduce your risk. But if the risk is high because there's a very high level of circulating virus, that's something that you need to take into as well. So unless you were able to get a 100% effectiveness, which we haven't got, then you would be wanting to take precautions at any time where you're likely to be exposed, which means, first of all, trying to avoid situations in which you are likely to be exposed and using other forms of protection like face covering to minimize the transmission anyway. But I'm sort of working from first principles rather than giving a definitive answer, but that generally tends to be the way I think about these things.
Thank you very much, Martin. Susan.
Thanks. Well, it's a really good question, and a question that really everybody's going to have to begin thinking about to some extent, because none of us are going to be 100% protected, and everybody's going to have different degrees of vulnerability. And we're going to have to move beyond a situation where we have rules and regulations that we need to adhere to a situation where we are able to assess the risk in terms of vulnerability and exposure and what's happening in the community around us, and take decisions for ourselves as to what level of risk is acceptable. And that will have to involve trade-offs because there can be trade-offs between mental health issues of staying inside all the time versus being able to go out when one knows that there aren't going to be people nearby that one's going to come into contact with, for example. And I hope that the government and Public Health England and different authorities will move to a situation where they begin to give us tools and ways of thinking about risk and how to translate that into our own lives, into our home situations, our traveling, our workplaces, being in public spaces, socializing, etc. So it's going to take a while, but I think it doesn't answer your question, but really just to say it's a really good question. And I think we collectively and much broader need to begin thinking about how do we help people going forward to live their lives in the long term.
Thank you very much, Susan. This is this question of how do we work out personal risk? How do we govern our own behaviour from what we know is happening in a population? It's extremely difficult. I wonder if I could come to you, Professor Cole-Friston, just for a final word on this.
Yes, of course. Well, the final word will actually just repeat the last two answers. So, I think Susan highlighted this is about risk assessment and acknowledging that everybody's risk is different because everybody is different. But Martin brought to the table the notion of basic principles. So, if you want to assess your risk, you have to have clear and quantitative criteria about what is presenting that risk. And it strikes me that exactly the same criteria can be applied to an individual, your father if he's shielding, yourself, or indeed a school or the community. So I suspect what will happen is that the criteria that we use for progressive and graceful and adaptive unlocking at a community level over the next few months will actually serve exactly the same risk assessment purpose in the context of making personal decisions. So put those answers together, and what we're saying is, if you're shielding, you should not feel that it is appropriate to expose yourself to interpersonal contact outdoors until you are in a green zone. At the present time, with present levels or anticipated levels of prevalence of infection, that would correspond to 10 per 100,000 infections in your local authority. And that's the kind of information that the government needs to supply to enable us to assess our risks, whether we're head teachers or individuals.
Thank you so much for that, Carl. And thank you for that question, Peter, and your wife. And that is all for today. I'd like to invite Sir David, as usual, for his summary and reflections.
Thank you very much, Alice. First of all, let me say that the news is good on the front of the development of the number of cases per day, etc. But when we look at the detail, it's 12,000 cases per day, it's 600 deaths per day. How would we ever, prior to this, have said this was good news? Right, so we've got an awfully long way to go before we have the level of disease down in this country to a level that we can be much, much happier about moving about in. What we've discussed is the notion of maximum suppression. How do we really get the disease level in the country down? We can't rely on vaccines to deliver this quickly enough, and we really have to look at other measures. Systematic strategy was developed in some detail at this meeting. And once again, and I am going to mention it again, find, test, trace, isolate and support, with isolate and support being given the emphasis it needs. We now are at the level where testing is at a high level, but we're still not managing the business of isolating those with the disease from the rest of the population so that the rest of us can go much more safely about our business. So we need that systematic strategy, please. Of course, the vaccination rate is high, but we are saying it needs to be higher. It could be run out much more quickly. and there should be a focus on that. I want to take this opportunity to congratulate the Prime Minister on his recent statement about assisting developing countries with supplies of vaccine, that these would be our surplus vaccine being given to developing countries. Excellent. But let's not focus entirely on the use of vaccines to get us out of this. It's going to be many, many months to go. Let's manage this well. Let's continue with managing the borders, which we've only just begun after a year. Let's make schools safe before we reopen their doors to our children. We are keen to see that this is managed properly and enables us to get out of this lockdown safely. Thank you.
Thank you very much, Sir David. Thank you to everyone who's watching. Thank you for questions today, and an enormous special thank you to our guest, Dr. Rachel Clark. And thank you, Independent Sage. All of the experts here are volunteers. They want to share their expertise, but they're also here because they believe it's important for scientists to listen to questions and concerns from the wider public. If you want to find out more about the biographies and the expertise amassed here, it's all on the Independent Sage website, along with all the reports and that new list of recommendations for emerging out of lockdown. Please do follow Independent Sage on Twitter if you don't already. We'll be back same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everyone.
Thank you. Bye-bye.
Bye.